About links with dementia, but particularly one thing that GPs often see is links with confusion. I mean, people can become acutely confused when they start these medicines sometimes.
Yes, and our work has shown that if you take these drugs for more than 60 days, that seems to lead to more significant confusion. And what I found from various educational events I've given is that GPs are not aware of the 101 plus medicines, and they're asking for a tool. So I'm saying there are tools out there, and that prescribers and pharmacists should have access to this tool and use it to then make clinical decisions.
Looking at the sort of drugs, for instance, bladder pills, oxybutynin is one of the drugs you looked at in your study, very commonly used bladder pill. Are there alternatives that we could be using that are better from the anticholinergic profile?
Yes, there are alternatively manufactured medicines, certainly in incontinence and bladder medication, but also antidepressants that definitely do not have this effect. And my message to people is, if they're there and they're not going to break the NHS budget, which many of them aren't, then why not consider it at least?
And I just want to make sure that that's covered. How's your waterworks now?
And it's not just anticholinergic bladder pills that can cause problems. Men with prostate problems are often prescribed blood pressure lowering drugs like tamsulosin to help their bladders, and the end result can be the same.
You're on the drug called tamsulosin. Do you think it's making any difference? Because it can make your blood pressure drop and can make you more likely to fall over.
No idea.
I would advise your doctor to see if we can get by without it. It's the balance between you going to the toilet frequently and the potential risks of being up and about and falling over versus a drug that might make you fall over. So it's a challenge, but that's between me and your doctor to try and balance that one out. So I would advise seeing if it makes any difference. If it's not helping your waterworks, then it's of no use to you. Unfortunately, this is the joys of looking after people with 16 medications.
Right there.
Incontinence is a massive problem, and we know that people who have problems with incontinence are at much higher falls risk because they're often getting up in the night, it's dark, they're unsteady. If you get up quickly, then you can get dizzy and lightheaded and you can black out. So it is really important that you address the continence, but the problem with these drugs is they can also drop your blood pressure, which means you get dizzy, lightheaded, and if you're not careful, you could fall over.
The patient you saw earlier in the clinic was on 16 different medicines, and I could see you going down the list of things, and there were 4 or 5 possible culprits there just on that one patient alone.
Absolutely, and that's not uncommon really. The standardised approach that we have now in medicine, which is entirely sensible for the vast majority of population, so aggressive control of blood pressure, etc., means that there will be 1 or 2, or particularly in the frailer population, a more significant number than that, who develop side effects to those medications, which then present. So as an example, we know that if you aggressively reduce the rate of high blood pressure, you reduce the rate of strokes and heart disease, but you also make people fall over. So you have to think, when the person comes in front of you, understand how frailty affects them, the increased risk of falls, cognitive problems, and how that drug might affect that individual.
I think you'll have GPs cheering at the radio hearing you say that. I mean, one of the problems that we have, certainly in general practice in the last decade, there's been a very push towards standardised therapy. We're rewarded for doing so. Treat the numbers rather than the patient. And what you're saying is perhaps we should be a bit more individualised, particularly when we're looking at people who are frail.
Absolutely. We need to think, when we look at that evidence base, is to say, yes, we know that reducing blood pressure is really effective, but what does that evidence base look like in a 90-year-old?
And what was that fictitious address I gave you?
42 West Street, was it?
West Street, but I'll let you have that. Perfect. 10 out of 10 he scored.
Nurse Jeanette Robson, Dr. Mark Baxter, and patients at their pioneering clinic in Southampton. And there's a list of the most commonly used anticholinergic drugs mentioned earlier by Chris Fox on the Inside Health page of the Radio 4 website. Now, it's time for the next instalment of Inside Language, our mini-series where Dr. Margaret McCartney and Professor Carl Hennigan demystify the language of medicine and research. This week, it's the turn of false positives and false negatives, both terms we use a lot here on Inside Health.
false positive is when you think something is true when it's not, and a false negative is when you think something is not there when it actually is. And the way I always think about it is, imagine that you've got a metal detector, you're in a field and you're looking for some kind of hoard of Pictish gold, and you're out there with your metal detector, and your metal detector goes off, and unfortunately it's just an old tin can that's underneath. That's a false positive. Whereas if you're going round your field, you find absolutely nothing, and then a month later a big farmer comes along with his tractor and he digs up a massive hoard of gold, you clearly had a false negative result. You didn't find your gold that you should have done.
Yeah, so let me try and put that into a context of, say, clinical. I think the one area where this has happened a lot to me is in prostate cancer testing and the PSA test. And a lot of people come in, want to test, and before it starts, I have to have this discussion about the test. What happens is, it will come back with slightly raised, and then people think, oh my gosh, I've got cancer. And then I have to go, hold on a minute, that could be a false positive result. Although it says the test looks positive, there's a chance actually you do not have the disease. And the chances are actually quite high that you don't have the disease. The flip side to that is some people say, hey, I'm okay, I've got a negative test. And I go, hold on a minute. Even though you've got a negative test, there's still a chance you can have a cancer. And actually we have to be mindful of that every time we test somebody. And it's often a really difficult concept to get your head round. The way I try and look at it is try and say there's something that goes with false positive and false negative is the likelihood ratio.